Should we go ahead?
Just 1 second, sir.
Has come. So we'll start.
Just cross-checking, sir, if it has started.
It is showing on the
Yeah, you can start, sir.
Yeah, thank you. So good evening, everyone, for our late night retina session. This is episode 2 of season 2. And we have Dr. Komal as our host today. And she's presently working as a vitreoretinal surgeon at Prakash Netralaya Kendra in Lucknow. Over to you, Dr. Komal.
Thanks, Avnish. So we are going to talk about macular neovascular membranes today. And on the panel, we have Dr. Sharath, who has been with us since a very long time and obviously doesn't require an introduction. And also we have with us Dr. Vishal Govindari. He did his fellowship from L.V. Prasad Eye Institute and is presently working in Hyderabad. So let us just jump into the interesting cases that we have for today. And so I'll invite Dr. Heenal Zaveri to start presenting her case first. Dr. Heenal, if you can share the screen.
Yes, ma'am. Okay. So hello, everyone. I'll be talking on the anarchic, that is the uncontrolled CNVM. So this patient was a 76-year-old male who presented to us with a chief complaint of diminution of vision in the left eye for 2 months. Systemically, the patient was a known case of diabetes mellitus, and which was under control with oral hypoglycemic agents. Visual acuity in the right eye was 6/6 N6, while left eye had 6/12 N8. Rest of the anterior segment findings were unremarkable. Just a minute, I think my slideshow is frozen. Yeah. So fundus examination in the right eye, the fundus was seemingly normal. Just a few drusen's were seen at the posterior pole. While the left eye, we can see some exudates and drusen's superiorly with a yellowish-white lesion temporal to the fovea, approximately 1300 microns away. OCT of the right eye showed few drusenoid PEDs. In the left eye, the foveal contour was normal. There was no intraretinal or subretinal fluid. Subretinal and sub-RP hyperreflective material was seen with hyperreflective dots. We ran an Octa scan, and Octa clearly showed a vascular network in the outer retinal and the choriocapillary slab. So a diagnosis of extrafoveal type 1 CNVM was made. Although there was no activity, and therefore we decided to observe this patient. The patient was asked to review back after a month. At the 4-week follow-up, we can see that there was activity. Subretinal fluid was noted. And at that point, we decided to carry on with transpupillary thermotherapy in view of an extrafoveal CNVM. So the parameters were 150 microwatt power for 1 minute, followed by 200 microwatts for another minute and 300 for another minute. Total energy of 55.9 millijoules was delivered. Immediately post TTT, we ran an Octa scan, and we can still appreciate the vascular network. Patient was then lost to follow-up for the next 4 months and presented in July on the 22nd of July for a follow-up. At this point, the vision was almost similar at 612 parts. Cataract changes had advanced and had progressed to a grade 2 cataract in the left eye. So on OCT, we appreciated the scarred CNVM, extrafoveal CNVM. And since there was no activity, we advised the patient to go on with a cataract surgery in the left eye. Patient followed up post-surgery and the findings were status quo. The vision had improved to 6.6 in the left eye. Again, the patient was lost to follow-up and patient presented back after almost 4 months with a loss of vision, reduction of vision in the left eye for 15 days. On OCT, we noticed that there was intraretinal fluid pocket and activity of the CNVM. Also, there was subfoveal lesion extending from the scarred margin of the extrafoveal CNVM. Vision had dropped as well. Vision was almost similar, but activity was noted. So on the octa also, we can appreciate that from the edge of the scarred CNVM, there is some activity and a new network is forming subfoveally. We decided to inject the patient with anti-VEGF. Ranibizumab was given. At 1 week post-injection, the fluid was noted to be regressing. And at the next follow-up, no activity was noted. A month later, also, the findings were status quo, but the vision had dropped in view of the subfoveal CNVM. We can appreciate somewhat a CFAN type of network extending from the old scarred CNVM area. So the next follow-up, there was some activity seen and the vision had further dropped. We again advised for anti-VEGF injection. The patient showed a good response to the injection with a reduction in the SRF and was asked to review back a month later. A month later, again, we noticed activity. There was intraretinal fluid noted and the vision was 6/48 parts. Injection was advised at that visit, and at the next follow-up, we noticed that there was good response to the injection. SRF had reduced while the vision was maintained at 6/48 parts. Patient was asked to review back a month later. Patient came back on 1st of October. There was no SRF. Vision was still maintained at 6/48 parts, no activity, and octa scan was also status quo. So to summarize the relapsing and remitting course, the patient underwent TTT. This was the OCT picture at that point. And post that, the patient has received 4 injections whenever we have noticed activity. We can see the progression of the network on octa as well up till the last visit, showing a somewhat of a pruned tree appearance of the old area, the extrafoveal CNVM area. And we can see the network in the subfoveal area. So my question to the panel is regarding the effectiveness and their experience with TTT in such cases of extrafoveal CNVM. Thank you.
Thanks, Enal. That was a pretty interesting case. And so first things first, I would put on this question to both Dr. Sharath and Vishal, and if Dr. Sharath can take this first. So would you have preferred doing an ICG and an FFA or an FFA in this case prior to the first treatment or the TTT that was done?
Thanks, Komal. Henal, it was a very nice case and a well-documented case. Coming to the question, if I'm planning for a focal laser or I don't have so much experience with transpupillary thermotherapy, I have not done or seen the transpupillary thermotherapy, but I do a lot of focal lasers sometimes for a non-resolving conditions. And it's better to do a FFA or a fluorescent angiography, ICG and a fluorescent angiography before doing the laser. So it helps us to see till what extent it is there. Most of the times by OCT wise nowadays we can able to understand, but in this case as we can able to see the stock. So sometimes the recurrence what happens with the fresh neovascularization which is coming is from the stock base of the stock. So if you do a ICG, we can able to see that, and I think we can cover much better laser if you do a ICG and FA. I prefer to do FA before doing the laser.
Thanks, Dr. Sharath. Vishal, your thoughts on that?
I think, first of all, thank you for having me today here, and thank you, Yossi. Yeah, I sort of concur with Dr. Sharath, especially with the feeder vessel laser, which has been tried quite frequently in PCV. So taking care of the feeder vessel is possible only if you've done a baseline angiogram, and if you have the facility of sort of a confocal, so that you can actually have a video to pick up the filling. So if that is available, that'd be great. But even a digital fundus photograph based ICG would be great to sort of reduce the dependence on injections as well as plan laser in a more long-term fashion.
So I guess, Heenal, this case was managed by Dr. Divyansh, and he's here with us. So I would, really appreciate if Divyansh can pitch in here and share his thoughts on why he did not or did angiogram in this case, and in retrospect, does he feel that would it be better?
Yeah, hi, thanks for the accepting the case. So this was the kind of management as we are seeing is very haphazard and haywire. The only reason is because the patient's concurrence to our advice. So we advise something, and sometimes patients don't follow in or do give consent for everything. So the answer is that we do expected that we wanted to treat him as a CNV as usual, but as we can see in between, he was just missing out on follow-up. So the reason for planning and TTT was that the area or the lesion was a little larger lesion. Focal laser, ideally in such cases, are not a good idea because focal laser, the maximum spot size you can do is 500 microns, and the lesion, as we can see, is around 2.5 to 3 millimeters. So in a TTT, the advantage is one, having a larger spot size. Second, the amount of energy which you are delivering is much lesser. And the second thing is the adjacent damage which is expected, the expansion of the laser which is expected. The cause for recurrence is, yes, always debatable that whether how much to cover, how far to cover. Yes, ICG FFA would have been the best marker. Octa right now gives us a very good understanding that what areas can be covered. So I knew what is the nasal edge and what is the temporal edge, and that's why I went ahead, because the concurrence of the patient of not getting follow-ups, not getting the treatment done was also there. So the in this scenario, yeah, I opted for a very unconventional kind of a treatment, but I expected more positive result. But in this case, and other studies have also suggested that in Indian scenario, the recurrence rate is somewhere at between 32 to 40%. So the recurrence, even if you treat with any laser for that matter, expect the recurrence. In this case, if the follow-up would not have missed, we would have achieved a better visual outcome and a better fovea. But yes, thank you.
Thanks, Divyansh. So that's pretty much the real world scenario that we have, patients not adhering to the advice that we give them or the kind of investigations that we want them to get it done. So completely understandable there. So moving on the discussion of TTT versus focal laser. So we have heard Dr. Divyansh's views on why he chose TTT instead of focal laser. I would love to hear views from both Dr. Sharath and Vishal on because they are more pro, as we heard, of doing focal laser. So Dr. Sharath, how do you choose your cases of doing focal laser, and what are the parameters that you look into when you do focal laser to these cases?
So most of the cases,
Please.
yeah, most of my cases are usually anti-VEGF nowadays, initially first line. So if it recurs back and if it is extrafoveal, that time I usually prefer for focal laser and add the VM said, if it is very large lesion, then I can't do the focal laser. But we don't have an advantage of transpupillary thermotherapy everywhere nowadays. So if it is a very less than 500 micron size and extrafoveal lesion, and once I try to make it dry, once the fluid gets regressed, then usually I do a focal laser. With keeping slightly on the deeper side power and more deeper penetration, I usually do the focal laser and higher spot size.
Vishal, your thoughts on that?
I hardly use focal laser, like Dr. Sharad just said, and I don't have access to TGT. So I think the opinion is not going to be a fair one. But having said that, one thing which we have had during my limited experience is focal laser can actually induce CNVMs quite, notoriously. There have been studies where people have tried focal laser for, for other reasons, where they've tried it for non-ischemic CRVOs to make RCAs, and that has led to CNVMs because of, the kind of duration you use, shorter durations, quick pulses onto the Brooks, which is like a glass. So it just cracks open. So focal laser can be dangerous. And we also had an experience, albeit in a patient with angioid streaks. We did a focal laser for an extrafoveal, and that ended up recurring and became a big mess. So I sort of am scarred on those lines. So I wouldn't use focal laser too often. I would tip towards anti-VEGF if I had to treat. And like I said, transpupillary, I have nil experience, so no comments on that.
Okay. So we have three different views here, and that's very interesting to have because of the availability of different things at different institutes. I'm just going back to Divyansh. So Divyansh, if you could just elaborate for for the listeners, how and what are the parameters that you use, or what are the things that you look into before you plan a TTT for extrafoveal CNVMs?
Yeah, thanks. Hinal, have we accumulated the data for the next patient I had suggested? So as she had suggested in the slide that we gradually keep increasing the duration and also the power. So we start with a lower power and a lower duration. So it's a long pulse, which is of a very high wavelength. It is a 810 nanometer laser, which is used, a red laser. And as you are seeing, initially the power is very low. The exposure is 1 minute. And then it's not the kind of laser how we do for a focal laser or like a PRP. So you would not actually see the scar at the end of the treatment. You would just see a faint whitening, and that also would be a very subtle whitening and deep. It's not like a laser, which would be like a chalky white. It would be a very deep whitening inside because we are gradually heating that area, and that's how the damage or either the destruction of the CNVM occurs. And as you're seeing that gradually the power is increased. So you don't go suddenly 300 because you don't know that if you start doing the laser, then you would start seeing a dense white scar. And once you see that scar, that means there is no point of return. So that's why you gradually keep increasing the duration and gradually keep increasing the power. And that's how you achieve the treatment. In cases of PHCR, yes, it's laser. I would somehow try to do it, but paramacular lesions, probably my choice, or extramacular lesions, my choice would be still TTT because we have the availability. Yes, obviously having an availability. So Sharath has asked two questions in TTT. One is how whether I do subfoveal. No, none of us do subfoveal. It was at the era where the anti-VEGF was not there, where the TAP study and the VPT study have suggested that means we are discussing a CNVM. So in that phases, there was nothing like PCV and CNVM. Everything was either classic, occult, or minimally classic, and then a combination of occult and classic. So response wise, all of them respond the same way. But as you're discussing the recurrence in Indian scenario, the study which is published by Sir group, means Mahesh sir and his group when he was in Shankanithrala, is that the recurrence is around 40%. But in cases of European studies, it is 95% suppression of the CNVM complex. So less than 5% of recurrence. We are not sure what the reason is for that. And what is the second question? Repeat TTT. In cases of CNVM, we would not want to do a repeat TTT, but yes, one thing in cases of tumors, what we do is an ICG enhanced TTT where the power is much lesser because the ICG would absorb the TTT and would have more targeted effect. But yes, it's not equal to or directly proportional to a PDT, I would suggest. I think there is one more question. So where exactly do you, sorry?
Yeah, that's from Nikita. So she's
Yeah.
asking where exactly do you put the spots?
So
the
it's
whole
as good as doing a PDT and having a GLD of 0.5. So in this case, as what I decided, and if we put the both the photographs together, the pre and post, I think we would understand the whole yellowish area is what my the target lesion was and where I have treated. If Hinal can put the last octa image, if we see the primary network which was treated by laser is actually showing like a dead tree kind of an appearance, and never it has shown any area of activity except this small frond which had come into the fovea and had caused a CNVM in the subfoveal area. Obviously the recurrence was expected, but as I told you, if we would have caught the patient somewhere in this July and in between this December, we would have had a better result, but unfortunately it was not possible. And right now, if you ask me what would be the best treatment, feeder vessel, because as we can see, there are two feeder vessels from the main trunk which are coming up, but the vision is so low that what is the point treating right now? So that's why I'm not treating. Thank you.
Okay, so thank you, Dr. Divyansh, for elaborating it so nicely. I'm sure that was very useful for all of us. Just one question again to both Dr. Sharath and Vishal. Do you miss PDT when you see cases like this?
For me, I won't. I'm not. I'm not pro PDT. Actually.
Not PDT person. Okay, Vishal. I'm
Would
sure
certainly say yes, because PDT really does have its charm, and we've seen, especially with PCV, the kind of results we get. So I'm pretty sure that PDT would be really missed in this situation.
exactly. Divyansh, you wanted to add something?
Yeah, same here, same here. Yeah. So I'm not sure whether the hen means the chicken and egg kind of an scenario where what is impacting better. But yes, when PDT was there, we knew that PDT is gonna flash all the PCVs, and at least 2-3 months we would be having a good time. But thanks for
I
anti-VEGF.
have had patients of just plain occult CNVMs, something very relentless, like how you had just shown, and one shot of PDT, and the patient is like stable since past 2 to 3 years. And so, yeah, we do really miss PDT a lot. Any other questions that we have from the audience on Facebook or YouTube, Agnish, if there are any?
So can I just add one more thing? So the TTT is not done like at staying at one spot. So you don't stick at one spot and then keep continuously giving the TTT. So you have to keep moving like this in a figure of 8 fashion, and then you have to keep delivering the energy in a different area, so that it's not that you are directly delivering all the energy at one particular area. So it's not like a focal laser where you keep delivering at 1 minute, you're continuously over there. No, it's not like that. So you keep moving like in figure of 8 and then keep covering the whole area. Just wanted to tell that.
Yeah. So we have one more question here. Dr. Sharath, you first. So in a case like this, when we have such a bad recurrence, we have seen that it has required multiple injections, would you still go ahead in an ideal scenario, go ahead with a PRN schedule, or prefer a treat and extend thing, or sort of switch to other anti-VEGFs, strategies like that?
The question is for me.
all I would like to listen to all three of you.
Take it. You answer. Let her answer.
Yeah, Divyansh, you can go
Okay.
ahead first.
So for me, in my early life, I was more towards PRN, but right now, treat and extend is what I am trying to follow up. As in this case, we can see that my plan is treat and extend, but not always the patients also
Exactly.
coordinate with that kind of an association. Regarding what anti-VEGF, right now, as we can see, subfoveal scar is pretty significant in this patient. So I don't want to jump to any other. He's comfortable with this, and that's why I'm continuing. But yes, there are newer anti-VEGFs which we can think of, but I don't want to try anything new in this right now.
Same here.
Vishal?
Yeah, I think. Yeah, go ahead, Dr. Sharath.
Yeah, same here. Like, it depends. Everything depends on what is the financial status of the patient, and if in the ideal situation, in the early phase, what he has come, I would have planned for anti-VEGF giving ranibizumab sometime, and nowadays the Pegenex has also come. But once in the later phase, as you see, how the event shed when there is already subfoveal scarring, I may not switch more to other injection and try a lot.
Vishal, your thoughts?
So one thing interesting in this case was that when he presented with the recurrence, it was a lot of Shrem to start with again. So it was already going down a slope which is quite slippery, and I didn't think the anti-VEGF, what type of anti-VEGF would have mattered, because you know that it's going to end up being a scarred Shrem, and then your vision is going to just drop down, because he was doing great with whatever visits he was doing, and it was 6-12 was his worst vision at presentation or after the cataract where he presented with the recurrence. But then when the Shrem kicked in and it scarred in, and then it just dropped. So I don't think the anti-VEGF mattered here. Switching anti-VEGF, rather I would ask everybody here if you would add a steroid, to sort of prevent the scarring. It's very anecdotal, but we have practiced this in a few cases, and I've had some okay results because of the amount of Shrem we see. Also, classifying the Shrem is very important. Are we looking at a scar itself while presentation, considering how irregularly he came, or is it like a lot of She, where it's more exudation rather than a scar? So these are more the things which were striking my mind when I saw this patient. Switch does matter if the drying effect is not there, but what Dr. Divyansh has done, the drying is pretty good. So I don't think there's a point of switching.
Okay, thanks, Vishal. So we are almost out of time, but we have a bit of questions coming up. I will keep those questions for the time that we have left, if any, after our second case and its discussion. So thank you, Dr. Heenal. Thank you so much. And thank you, Divyansh, for bringing out such a nice case. We had such a nice discussion, and thank you for teaching us so much about TTT as well. So now I would like to invite Dr. Shishir to please share his case.
Yeah, can you see the screen?
Okay. Yes, Dr. Shishir, you can go ahead.
Yeah, so thank you, Late Night Retina team and Yossi, for giving me this opportunity. So I'll start my case. So this was a 13-year-old male presented with decreased vision in the left eye since 1 month. He had a history of night blindness, no other systemic illnesses, no hearing loss, no history of any trauma. So the parents and he had a younger male sibling who were examined, and they were normal on ocular examination. So vision in the right eye was 6.6, anterior segment was unremarkable, left eye vision was only 6.12, anterior segment again, it was normal. So coming to the posterior segment, so this is the fundus examination of the right and the left eye. So in the both eyes, there's widespread areas of chorioretinal atrophy with presence of pigment clumping. And then at the fovea and the perifoveal region, you can see an sparing of the RP and the choriocapillaris, which is in the shape of an island with some pseudopodia-like extensions. Also, in the little bit in the mid-periphery and the equator, you can see these outer choroidal vessels, indicating that there is a loss of choriocapillaris there. And the same features are present in the left eye, but additionally, there was a presence of subretinal hemorrhage just seen adjacent to the fovea in the left eye. So OCT was done. Right eye, we can see generalized retinal thinning with outer retinal deficits, and there is loss of RPE and the photoreceptors, except it's spared at the fovea, and there is gross thinning of the choroid and loss of choriocapillaris. Only the choroid is slightly thickened, especially at the subfoveal region. And same findings in the left eye, except the fact that there is presence of subretinal fluid and subretinal hemorrhage as seen in the initial first scan. And then you see a hyperreflective material, which is seen in this second OCT, suggesting that this could probably be a neovascular membrane. So an octa was done, and this is the octa of the right eye, which shows only choriocapillaris sparing in the foveal area and the parafoveal region, whereas everywhere else there is loss of choriocapillaris. Only the outer choroidal vessels are seen. And additionally, in the left eye, there is presence of a neovascular network, which is picked up on the octa. An FFA was done. So again, on the FFA, widespread areas of RP atrophy. So hence, you can see the choroidal vasculature can be seen very clearly on the FFA, except for the central region where the choriocapillaris is spared. And so this is the late phase. So this is the right eye. And in the left eye, we see a early small lacy pattern just adjacent to the fovea and at the region of the foveal avascular zone. And in the late phase, we can see leakage there, which is very minimal. So this, I couldn't get a color montage, but whatever I could gather from an FFA montage, we can see that there's widespread atrophy even in the peripheral retina in both the right eye as well as in the left eye of this patient. So an ERG was done. There was reduced scotoptic response. So it was diagnosed as both eyes choroideremia with left eye neovascularization secondary to the choroideremia. So after talking to the parents and in view of MNV in the left eye, we planned intravitreal ranibizumab, and right eye was under observation. So patient underwent 4 injections of ranibizumab monthly apart. So initial vision was 612, and there is, after the 4 injections, there's resolution of the fluid and the resolution of the hemorrhage, as we can see post-treatment in this OCT of the left eye. And also the hyperreflective complex has become small, it has shrunk and it's become slightly smaller in size as compared to the initial scan. And also on the octa, we can see that in the left eye, the vascular network has actually shrunk and it's appearing little more condensed. So at 6-month follow-up, there was a disease reactivation where his vision dropped from 6.6 to it became 6.9, and then there was subretinal fluid. And after again 1 dose of injection ranibizumab, he vision had improved to 6.6, and then again you can see that small neovascular hyperreflective small network, which we can see on the OCT here. So he was followed up for 3 years after that, and he was stable. So question to panel. So what is there is importance of preserving the central visual acuity, hence definitely to identify these cases. Any role of octa for monitoring these patients, and whether to call them very frequently, and general discussion about the pediatric choroidal neovascular membranes. So this we had published in AGO case reports and also included this patient in this pediatric CNVs, which we had published in EGO. Yeah, thank you. Over to the panelists for discussion.
Thank you, Dr. Shishir. That was very interesting and a pretty rare case to see a choroideremia, and that too again with a CNVM. Very notably in a 13-year-old, the choroideremia is so much advanced that we have only the macula left. So I would just take on the discussion on the CNV that we see in cases like this. So Vishal and then Dr. Sharath, what do you feel in your experience? What kind of dystrophies or degenerations you see which are more commonly associated with CNV as their complication on their follow-up?
So for me, I think the one which I always look out for is BEST. BEST is quite commonly, relatively quite commonly associated with CNVMs because we've seen a lot of RP, or should we call it rod cone today, and a lot of other dystrophies where you hardly see. I mean, maybe my experience is very limited, but for what we have seen, it's very rare to see CNVMs in this kind of degeneration, especially this kind of advanced burnt out pictures. But yes, BEST is something where you are more on the lookout. For me, BEST is something which I would certainly say tops the list.
Dr. Sharath?
Yeah, it's a very interesting case. What I'm seeing, I have never seen a case of CNVN in a choroidemia. This is very classical. The most of the times, any dystrophy they have subtle CNVNs. The most commonly, what I have seen in 2-3 conditions. The most common, as Dr. Vishal said. So best once they go in the atrophic stage, they may develop CNVN more commonly. And I see also in the brittle crystalline dystrophy, which is a variant of RP. I have seen 2 to 3 cases developing CNVN in those conditions. And also another condition what I seen is Sorbis dystrophy. So these three, I think, for where I usually have a more follow-ups when I see them.
Right. So just on that point of follow-ups of these patients. So I guess with the kind of experience all of us have had, and we have listened to both Dr. Sharath and Dr. Vishal, it's very safe to say that if we have a vitaliform dystrophy, BEST or bestrophinopathy or something related to that, it is more prone probably to develop a CNV later, and we would want to follow them up comparatively more earlier, or give specific instructions. So on those lines, Dr. Sharath, dystrophic cases, how do you usually follow them up? And once if you have a CNV, you treat it and now it is stable, then how you sort of follow them up for recurrence?
So for the screening part of it is I am not changing a lot. So every follow-up when they come, usually we do autofluorescent, OCT, and OCT angio if you have. Then if not, I'm not, there is no features of any CNVN development or anything. Usually we keep it yearly once. And once if they develop CNVN, because they are very subtle CNVNs and they respond very well. And once they regress, then usually I call every 4 months. And I will usually I do OCT angio to look for. Fluorescent angiography baseline I do sometimes if I suspecting CNVN, or else fluorescent angiography rarely I do in these cases after the OCT angio which has come.
Yeah. Vishal, your thoughts on that?
So most of these, like Dr. Sharath said, respond very well. Many of them are classic and they're very fast to respond. And like Dr. Shishir has very eloquently presented, with good visual outcomes of whatever macula is left. So I would follow up annually with autofluorescence, fundus photography, and OCT. And there's a CNVM, once in 4 months or once in 6 months, once it is resolved. And FFA per se, if you don't have an Opta, yes, I would do an FFA. Otherwise, Opta to follow up would be great.
Yeah. So just on the lines of the discussion of using an FFA or an Opta in cases like this, do you feel that Opta has an edge over an FFA, especially like it is unrelated to this choroideremia, but like especially in cases of BEST where you already have some vitally formed deposits, and it sometimes can get difficult for us to know where is the CNVM, where is the deposit, where is the scar, which is going into the atrophic phase. Do you feel Opta has an edge over FFA in these cases?
Actually, one problem happens in this, during the Opta. So Opta requires a more fixation, and these patients, whenever they have a BEST disease, if they go for the atrophy stage, they don't have a good fixation. So getting a good Opta is very, very difficult in these cases. So we should try to make them fixate properly. It's very difficult for them, but we need to try to fixate. We need to see there are very less number of artifacts and all. So that time I feel FFA will be better. If I have an option of ICG, that also will be good to look for. But yes, if we get a good picture Octa with less artifacts, we can treat only with Octa only, I feel.
Vishal?
I'll slightly differ on that because we've had a lot of experience in chronic CSR where may not be related to this condition, but you all have a lot of noise. You have a lot of choriocapillaris loss. Maybe the anatomical change is same, and the FFA is always two-dimensional. So you're going to have a very binary picture of hypo or hyper. And for you to differentiate, this case has been fantastically imaged, and the kind of presentation where you have an island of active retina has actually brought out that leak. And of course, there's a subretinal hemorrhage helping. But it becomes very challenging sometimes to pick up when you have a completely burnt out retina. And also it's two-dimensional. Whereas Octa, if totally agree with what Dr. Sharath said, the challenges and the acquisition times are pretty high in Octa, so it can be very challenging to have them fixed. But if you can get a good image, then the thing is you can sit and segment it, and then you can pick up every layer you want, and you will be able to pick up data which you want to see. So I would certainly say Octa does score. It is a very niche sort of requirement of Octa, but yes, it would score in this situation.
Right. We have two different views there, but I guess nothing is black or white in cases like this, and the areas of gray is what we come up with in discussions like this. But it was a very interesting point, Dr. Sharath, that you made, that while we know that Octa is going to give us more information, but getting a good image can actually be challenging. And that is something most of us, while we are discussing cases here, we tend to sort of overlook or sort of not really discuss that fact, how difficult actually it is to get a good nice Octa without artifacts if the patient does not have a good central fixation. Okay. Again, so moving on to the outcome of cases like this. So Dr. Shishir here mentioned that he had to give 4 injections before the CNV stabilized. In my personal experience, not with choroideremia, but in BESS, I have seen that they respond pretty well and pretty fast to anti-VEGF injections. So I would love to hear first, actually Dr. Shishir's view on that and his experience with other dystrophies, and then Vishal and Sharath, of course, on what is their experience on the kind of outcomes that they see in these cases. Dr. Shishir?
Yeah, so have few experience in treating these few dystrophy, especially choroideremia, and we had treated 4 eyes with BESS disease. And like you correctly mentioned, BESS, sometimes it's quite difficult to know whether it's actually a network which is subfoveal or whether it's the vitelliform deposit, especially even after when you do an when you do an OCT, you don't really know. So there the Octa really helps in differentiating whether it's a network or whether it's a like a vitelliform material. And these pediatric CNVMs, especially secondary to these dystrophies, if picked up early, they respond really well, and they require a less number of injections as compared to the ARMD or AMD or wet AMD CNVMs. So they behave differently, they respond differently. And the first thing, and earlier, before the era of anti-VEGF, always they used to observe these cases because pediatric CNVs have a tendency for spontaneous regression. But now in the era of anti-VEGF, so definitely that is the first line of management. And in these dystrophies, especially these rod cone dystrophies where the peripheral visual field is already constricted, it is of prime importance to save the central vision. And it's important to identify and pick up these CNVMs really early. And they respond really well to treatment. Some of them, they even respond maximum 2 or 3 injections. They won't require so much frequency of injections.
That's a very important point that Dr. Shishir has mentioned here, that it is very important for us to identify the cause of loss of vision if the patient comes with a sudden drop in a long-standing dystrophy. and CNV being one of the prime causes. So just one more question to Dr. Shishir before I move to Dr. Vishal and Sharath for their views on this. In the paper that you showed on the pediatric CNVM study, your group has published,
Yeah.
did you also see that the recurrence in these cases in pediatric CNVMs is much lesser than what we see in adult CNVMs?
Yeah, so in the paper, the most common cause of pediatric CNVMs were inflammatory, followed by idiopathic, and then fundus dystrophy. So among all the CNVMs in pediatric, the mean injection rate was around 2 to 2.1 or something, as far as I remember. And the only case which had a recurrence was this choroideremia case. None of the others had a recurrence over a period of 36 months of follow-up.
That's pretty great, and that's very good to know that these CNVMs do pretty well once we treat them quite early. So moving on to Dr. Sharath, your experience on the outcomes of these patients and recurrences.
I have treated around 3 BISH disease CNVN and around 2 CNVNs of beta crystalline dystrophy. Okay, in that I won't follow 3 loading dose for these things, as you know, for many myopic CNVN part of it. The BISH disease, they did pretty well. Anatomically, they did pretty well. The CNVN got this thing. There was no activity for the next 2 years part of it with the two injections. But beta crystalline dystrophy, they had a slightly different thing. One patient did well, and the other patient, they didn't do well. The problem what happening is that anatomically there was a scarring, but you're not able to see any difference in the vision or any other, because already there was happy atrophy involving the macula also. So overall, I feel these dystrophies, they work very well with anti-VEGFs, and most of them are subfoveal in these conditions. So we have to go. I won't do laser or anything. We usually go with anti-VEGF.
Yeah, Vishal.
So I think everything which the both of them have said has basically summed it up. Nothing as such different, but one point which I would say, we have treated a few 3 to 4 cases of BESTs. And what I could see in those cases was that most of them presented quite dramatically. There was this hemorrhage which always pointed where you don't expect it in BEST, and the patient has very good vision till a very late stage in BEST, as we all know. So that was something which was a giveaway for these CNVMs. But having said that, anatomical response is very fast, and vision did recover quite well in these cases. So this is my take on this dystrophy-related CNVM.
Right, thank you. And if Divyansh is there, Divyansh, if you have any point to add here. Okay, so I was, when we were having all this discussion, I was just wondering that all of what we are talking is so much anecdotal and so much on, the kind of experience that we have had. Because these cases are so rare, the dystrophies itself are so rare to present, and a dystrophy complicated with CNVMs again is a more rarer entity. I would, sort of really love to combine our cases and probably put out out as a publication from the young ophthalmologists actually, and how their experience have been on treating these cases. So welcoming on, sort of giving a shout out for all those who are listening to this episode. If you have cases like this, we would really like to sort of get them together and publish it. We have one more question. So Avnish has put it up here. So best vitiliform lesions and difference from CNV, what are its markers? I am not sure if I get the question correctly, but I guess it probably speaks on OCT. How do we differentiate whether it is a vitiliform lesion or a CNV? Is that correct, Avnish?
Yeah.
Yeah, so no, Vishal and then Dr. Sharath, your views on that?
So, sorry about that. So to sort of differentiate between the two, on the OCT, it's going to look the same unless and until you have a clinical feature. You could look at visual acuity as one marker because you don't expect a best patient to suddenly drop in vision. The other thing is, with regards to a fluorescent angiogram, you can look at a very early phase and sort of pick it up. But if there's no bleed and you're looking at a pseudo-vitelliform stage where you have an empty optical space, then it does become a challenge just based on OCT to pick it up.
Yeah. So just Vishal on that, do you feel, or in your experience, do you feel the kind of CNVMs that we see in BEST or other dystrophies are more classic in nature as compared to occult? And would you feel that that would make a difference on how it looks on the OCT, or have more intra-retinal changes along with the pocket of that optically empty space, sort of
Yeah, so
thing?
they do tend to be more classic, but then this is again extremely anecdotal and it's not fair to say make statements on these lines. But yes, because the way they respond and the way they appear on the OCT, yes, they do tend to be more subretinal, predominantly subretinal in location. And intraretinal fluid can be a sign which happens quite late in the course. So again, we lose that advantage because if you see even what the case which Dr. Shishir had presented, predominantly it was subretinal fluid. You hardly saw any intraretinal, and it just did that despite such a long follow-up. So I don't think it's going to help. It is a very tricky thing to have, and unless and until you have some stark sign, it's going to be a challenge always.
Dr. Sharath, your views on that?
Just sorry, you want to first coming to this thing, Avinish question, what are the biomarkers? So one thing what we can see the autofluorescence. So usually if the vitiliform, it will show a hyperautofluorescence lesion than the CNVM, which may show hypo. And the second thing, if you see in the OCT, so most of the times the CNVM which is there is usually very irregular and it suddenly lifts up. But the vitelliform dystrophy, the vitelliform deposits which are there, they won't be sudden elevation in the deposit. It will be like a gradual elevation and depression, how you see like a CSR fluid. So that also helps you to differentiate sometimes to whether it's a vitelliform deposit or a CNVM. And yes, most of the cases are subfoveal and classical CNVM what we see, type 2.
Right. Thank you. So thank you, Vishal and Dr. Sharath on that. Dr. Shishir, if you want to add something to that. You're muted.
Yeah, regarding the type 2 CNVM, majority of these CNVMs, which are secondary to these fundus dystrophies and even angioid streaks, all of them are usually subretinal, and they are type 2, and they respond and they're known to respond well to anti-VEGF. Rarely we see, even in our cohort which we published, all of them were type 2 except for one patient with trauma. That's all. Yeah.
Correct. So I guess that pretty much sums up the case that that was presented by Dr. Shishir. And so thank you so much for bringing out this case, Dr. Shishir. That was very wonderful. And thank you, Dr. Sharath and Dr. Vishal, for such a great discussion that we have had. If there are any other questions, we might have 6 minutes to go. If there's anything that anyone would want to put up or discuss or anything. So there was this question that Vishal had put up for the previous case. If or do you prefer adding steroids to cases where you are seeing such a shrum? Dr. Sharath, your views on that?
Now, after this latest anti-VEGF which has come, Eylea and Begenex, I have stopped doing the steroid combination actually, because I didn't see much difference when adding the steroids. Previously, I was giving anti-VEGF with one or two cases I given with Ozurdex, and one or two cases I given with IVTA and Kinocort, transeptal Kinocort also. But now I switch the anti-VEGF nowadays.
Okay. So again, to the time when you were giving steroids, which were those cases, or what do you see on the OCT or the Opta that,
So initially, correct. Initially, when you see, if you see a lot of, SHRM has it or subretinal hyperreflective materials or hyperreflective foci, these hyperreflective dots, what you see, if clinically they are not hard exudates, and if they are usually the outer retinal areas, so that indicate there can be some amount of inflammation or a component of PCV. Those conditions I prefer to, I was adding the steroids.
okay. And do you, would you add steroid at the, to a naive case like this, or where you have
No.
given some anti-VEGFs?
Usually, if it is not responding or a recurrent, that time I usually do that. I'm not done for a nerve patient.
Okay. Vishal, what are your cases where you add steroids to your anti-VEGFs in CNVs?
I would look at the SHRM component quite seriously. Again, it's something which I have a small case series of, which has gone both ways. Steroid does come with a pinch of salt that you can have your IOP spikes. So yeah, with a lot of SHRM, or if there's a very large PED which has a high chance of RIP. We've also had this discussion when we were in training, and we did use steroid there in combination. I have used steroid in a few patients, not in a couple, more than a couple, and the RIP did not happen. But I don't have a case control study to prove it. But yeah, these are the two indications where I would use steroid, and I would try to, if I want to give, I'd give it in a naive patient. I wouldn't go ahead and wait. And the whole point of giving the steroid is lost if you're going to not give it in a naive patient, because then you're again asking the SHRM to go and scar, which beats the purpose of giving the steroid.
Okay. So that's an interesting viewpoint. Dr. Sishir, you wanted to add something to that?
Yeah. Just a question to panelists regarding that TTT. Just thinking, I mean, it causes a little more of a depth. It has a better depth penetration as compared to focal laser. So do you think there in that case, the TTT is the cause of the secondary CNVM which has come? Especially when you're treated the edge and you caused a scar, you caused RP, damage there. And then there's a VEGF, this thing, and then there is a new CNV network from the edge of the old CNVM. I couldn't find any reports on TTT inducing a new CNVM, but I'm just a thought.
Possibilities are there to have inducing the CNVM due to this thing, but see, many case reports, as you said, has read many case reports, there is a high chance of recurrences after the TTT also, which even Dr. Divyansh was saying. So it becomes very difficult to say whether it's the TTT which has induced the CNVM or it's a recurrence. Because if you see the new CNVM which has come from the edge of the previous car, which is there, that from the stock what you are seeing. So there was no new break, or there is no new, somewhere from other place, the new stock or new CNVM has not come. So it's very difficult to say it's because of the TTT or recurrence.
Vishal, if you want to add something to that. Okay. Okay, just, sort of my viewpoint on that. I sort of believe, or I would err on the side of probably, when the TTT was done. So maybe because it was not ICG guided or not FFA guided, maybe there was one small twig of that CNVM which had not properly closed, or something which is, not really sort of can be picked up on an OCT that much. And if that recurs, and because it's supposedly on the nasal side of the CNV, then probably it has grown subfoveally. That is what I would, want to believe when I see that case. But again, as Dr. Sharath mentioned, it's really very difficult to say whether TTT induced it. So we have seen some
Sorry.
Yeah, sorry. So Vishal, you're back.
Yeah,
So
go ahead,
we-
Komal. Go ahead.
Yeah, no, we were just sort of discussing on whether the recurrence in the case that Dr. Heenal had presented, whether it was a, sort of TTT induced CNV or
No,
it was just,
I got it. I got that.
yeah.
So I just wanted to say that, yeah, the chance of it being the recurrence, like Dr. Sharad said, is possibly more likely, because though the reports do say that the kind of mechanism you have for any sort of thermal injury to cause a CNVM is very different. This is a more longer acting longer wavelength, as well as a longer acting thermal injury, which TTT is causing, as opposed to what has been traditionally understood to cause CNVMs because of these injuries. So considering what Dr. Divyansh said as a 40% recurrence chance, I would slightly sort of tilt my hand towards, it being a recurrence rather than a TTT-induced CNVM.
Yeah, so that's what we, sort of all believe when we see that case. Okay, so we have just sort of completed our time, and it was wonderful having this discussion with all of you guys. I thank all the presenters and both of our panelists for being here and we had a great discussion. And thank you especially Dr. Divyansh for being here and share your views on TTT, and we learned something new today. Thank you so much. Dr. Avnish, you would want to take up?
Yeah, thank you, Dr. Komal, for this elaborate discussion which we had. And thank you all the panelists, our viewers, as well as our presenters. And we'll come back with more case discussions in the future. Thank you so much, everyone. We can call it a close. Yeah, thank you.
Thank you. Thank you, everyone.